Good evening. How's it going, Dr. Salem?
Great to see you, Dr. Amos. How you been? How's your day going over there?
Doing fantastic. Like usual, busy day.
Oh yeah. No, it's great. It's a new year, and I feel like a lot of people have a new, definitely like a new energy, and yeah, we're excited to have some of those people on board here to ask some questions.
Yeah, it's I'm actually really excited about next week. I know we weren't really even planning on doing much today, but we thought, hey, we wanted to just give people a chance to ask any questions they wanted tonight. But I think it's really exciting about next week, what we're gonna have on our guest.
Yes. I think that's going to be a fantastic show. Kind of a deep dive into that topic, around fibroids, around management of fibroids, and some of it will, of course, relate very specifically to fertility, and other stuff might relate more generally. And I think that's a really exciting opportunity to just kind of talk to the whole, just all of the listeners that are out there, whether they're considering fertility or not with regards to fibroids. So, and we have a really special guest on. So yeah, I'm very excited about that.
Yeah, really, really nice guy, and he's one of this guy takes out fibroids that are just humongous. I mean, size of like basketballs. And any questions you have, really get them ready next week because it's gonna be a pretty exciting episode. And he's a fun guy, and good looking guy too. So I think a lot of you guys will appreciate that. Unfortunately, you got to look at our ugly mugs every couple weeks. So
yeah, we're gonna refresh it a little bit for you here. It'll be good for everybody, I think.
Exactly. So, but tonight's gonna be fun. I hope everyone enjoys. Tonight, and just feeling free to ask any questions they want, and we just kind of go over things. Anything before we get some questions? I know we have some people already putting questions, and some people in the background. But anything you wanted to bring up tonight, or?
Oh my gosh, there's so many, and I know that we have some people who have kind of sourced some of our insiders have sourced some questions from the internet. I mean, some of these I just saw them and I love them, just because I would love to tackle them. But yeah, we can really start this however you want. We can start with some of these questions that we're getting here online, or however you'd like to take it, Dr. Amos.
Yeah. I think let's just start with some of the questions that people have, and like I said, we'll let people come on and ask their questions as well, or as they're sending them. I know one of the things we want to do is help bust some of the myths out there in fertility, and that will probably help people. On my side, I saw one question came up was, what's your take on plasmapheresis and fertility? I'm not as familiar with that being used in fertility other than for some minor medical issues. But you know what they're talking about on that specifically?
Yeah, I'm trying to think of how it would be used. I mean, the idea of plasmapheresis is to kind of scrub almost the blood of certain,
Okay.
yeah, exactly, antibodies, antigens, things of that kind. So I'm not 100% sure how it's been used. I can say it's definitely not something that's mainstream, because anything that's mainstream, would have made its way here pretty quickly. But I don't have any more insights on that one. That's an interesting one. I might have to go back and look to see if there's anything new with that.
Yeah, I agree. Usually you think of it like disease and stuff, hemochromatosis and things like that. And that's what I said. But the only thing I can think of, like you were saying too, is infertility, is if maybe people have like recurrent miscarriages and stuff, and maybe the thought is like you're removing some type of antibody. But I encourage them to come on and let us know, and I think we'll be able to be able to see it. So, anyways, we do have someone here. Let's pull up Cassidy here for a second. And hi, Cassidy, how are you doing?
Hey, how's it going? I'm good, thanks.
Hey, I remember last time when we saw you, you had some questions for us. And I felt bad because we had to keep moving on to some other people. But tonight, I mean, that's all it is. It's just pure questions about, questions you guys have for us. So hit us with them.
Well, since the last time we talked, there's been a lot of change in our life. We went through, my wife and I both went through egg retrievals. So now that we've done that, we have questions about, like transfers and egg quality. So this one's about egg quality. or excuse me, embryo quality. So at this point, for one of us, we have 3 blastocysts that are frozen. But the question is really like about whether we should continue to do another egg retrieval because of the grading for these embryos. And just like for, I guess, the background, there's, one of the embryos was frozen at day 6 and the other 2 at day 7. And those are kind of like, from what we've read, like late stage kind of, like ideally it should be around day 5. And then the gradings aren't amazing, right? We have one that's a C, B minus, and then 2 BBs that were day 7. So that's kind of the question, like, do we just say these aren't really the best quality? We should just try to bank more embryos and try to get something better before we do a transfer. Yeah, I'll leave it at that.
I mean, I know Dr. Sam will have, some similar thoughts on this. I think one of the things that's important to understand is all of these things like grading, when they're frozen, all that stuff is more just about statistics, right? So grading is not actually as good as we thought it was. That's the reason why when you do PGT testing, if you know an embryo is normal, it can outweigh, let's say, for example, if one's an AA, but one's a BB, you would assume that the AA is the normal one, but it may be the BB. And so if you went and you took, I always tell people, like, if you take a triangle and say, okay, let's have a triangle, and if A's are at the top, B's are at the middle, and C's are at the bottom, okay? And you said the embryos are at best, right? A's are the best, fewer than B's and C's. What you would find is you find the pregnancy rates are very similar. A's do better than B's, B's do better than C. But what's interesting is then, if you actually went and looked at that same thing and said, well, which embryos end up being more euploid? You find the A's end up being more euploid than the B's, and B's end up being more than the C. But once they're euploid, that difference starts to be a little bit different now. Now, all of a sudden, the A's don't have that big of a benefit over the B's and C's. Now, there is some truth about the difference between day 5, 6, and 7. What's interesting is we actually just went and looked at our 2024 data, and there's some day 7s that have almost a 50% pregnancy rate. Now, part of that is because we've went and we keep looking through our data all the time, and we looked at to find out, like, is there any groups that really just aren't getting pregnant? And what we found is the CC day 7s were so low, the pregnancy rates, that it wasn't even worth doing anymore. And once we removed that, all of a sudden we started to notice the pregnancy rates really went up on the day 7s. Now, there's no question they're going to be lower, but I want you to at least understand that kind of grading system, that don't put so much onto that, okay? In the end, if it's an embryo that's euploid, it can work. And then that's the question I think that comes in. I always talk to people is when you're talking about your family, what is your ideal family size, right? If you're like, we just want one, then absolutely not, don't do any more retrievals. If you're like, no, we want 4 kids, that answers it for you right there. You're not going to get 4 kids out of these 3 embryos, right? And so that's kind of the way I would do it. But I always tell people, if you have 1 embryo and that's all you want, I don't care if it is like the worst quality embryo in your mind, the worst grade. At the end of the day, it will work. And I literally saw a patient today, same situation, very poor quality embryo, meaning like on the lowest, and she got pregnant with it. And that's why, I always tell everyone, we don't freeze anything. Now, again, it doesn't have to be our clinic. Any clinic usually won't freeze something that won't get you pregnant. That doesn't do anyone any good. So that would be my answer. I'd love to hear what Dr. Sam has to add to that.
Yeah, no, definitely. I mean, I think, going back to like maybe your original question too, you're like, well, I heard, should we bank away more embryos, or should we, start transferring these embryos? And I think there's like sometimes one additional thing to think about. Like Dr. Amos was saying, like, let's say, first of all, you're hoping to have, 2 or 3 children in the future. But statistically, we're looking at it and we're like, well, even if we have 3 euploid embryos, with day 7s, you might not get 3 children from that. So a lot of people will say, well, let's go through another cycle, retrieve more eggs, try to see if there's any small tweaks that we can do. I mean, there's no guarantees, but a lot of times we learn a lot about your cycle from your first cycle and see if there's any small tweaks. Then let's say you get another batch of embryos. All of a sudden you have 3 or 4 more embryos. And now you have a day 5 in there, 2 day 6s, and a day 7. Well, it might have in some ways also changed how you think about your family planning goals, which embryo potentially you start with the transfers with. Maybe now you have an embryo that has a higher chance of success right out of the gate, so it makes your transfers a little bit more successful. So I always like to also kind of think about it, kind of globally, holistically like that. But what we do know is that the embryo quality does not translate in any way to baby quality. And I always remind people of that. Like, this whole embryo quality thing really throws people for a spin, because they're like,
Yeah.
oh, I feel so bad transferring like a day 7, BC. But the whole grading system was just made around this idea of implantation. It doesn't say anything about the health of your baby. And so really important to remember that part as well.
And I just thought of another thing when you were talking. It's also the age of the person, right? So if someone is 25, 27, they have years to still do this. If your egg reserve is good, you don't have to keep banking a bunch of embryos. There might be a cost advantage to it, and I get that. But now if you're 38, that's a different story, right? Now you're like, hey, I'm not going to be able to do this as well at 40 years of age. But the difference between a 20-year-old and a 32-year-old is almost zero. And so you have to take all that into consideration when you're really thinking about doing more cycles. I actually look down. I don't like how I see people doing lots and lots of cycles. I think a lot of clinics push this a lot. Yeah. I feel like you end up with a conundrum later, right? Then you start thinking like, what do I do with these? And even if you feel comfortable discarding them, there's still that feeling later of like, do I have to use it? And so I tend to look at, what do you want? Your ideal family size. Do you care about things like gender? And then again, what's your age? But never worry about the grading. I can assure you, especially like at our clinic, we would never freeze something that couldn't get you pregnant. So if it's frozen, there's a chance.
Yeah. So I guess a follow-up question to that is, how do you make the decision between a day 6 and a day 7? In our case, our day 6 has a slightly lower grading, right? It's a CB, where our day 7s are BBs. Like, how would you choose between those if you're going in to do a transfer?
Yeah. So that's again where you have to look at like your clinic study. So again, I could not tell another clinic. In general, a day 6 does trump a day 7 in some ways. I mean, just because day 7, I'm telling you, like, it wasn't until just a minute ago that people were even doing day 7s. I mean, it was like day 5, day 6, done. The thought of even doing day 7 is well. Now there's even papers out there talking about how these lead to live births and stuff like that. So it's kind of new, but we still know the chances are a little bit lower. There's no question. Like I said, though, we're looking at our data, and after making some small adjustments and really grading them in a way where we say, okay, we're not going to freeze certain ones. We're seeing in some groups up to 50% pregnancy rate. So that's almost as close as you expect for a day 5 or day 6. So I would say it comes down to what's important to you. If it's a gender thing, then pick the one the gender one. If it's not, then put back the best embryo, and your embryologist will decide what's the best one. They'll look at all those features. They'll look at the quality of the embryo. I mean, we even look at pictures before we pick the embryos. We'll look back at the pictures before they were frozen and see if we think one looks a little bit better, because you have to remember, like, all of those grades are put into a few letters. Mm-hmm. I for people who use the system, the ABC system, because I'm like, wow, you have to fit everything between 3 letters. And even us, when we have 6 letters, I mean, still you're talking about, one maybe has 100 cells, other one has 105 cells. Do you change that the code now to an A, or is it still a B or a B plus? And that's the point I'm bringing up, is that it really comes down to what you feel comfortable with. If you feel that you care about gender and your day 7 has a certain gender, put that one back. At the end of the day, all you care about is having a baby. Your baby's not going to be any smarter. It's not going to be any healthier. It means none of that. It's just the implantation potential. At the end of the day, if I want a girl and I know that's a 5% lower chance, but I can have a girl, I'm taking that chance every time. It's not the difference of not working and working. It's just implantation potential.
Got it. Thank you.
One other question. Anything else you got for us, Cassie? You always got good questions.
Well, I was just asking my wife if she had any follow-up questions, and she doesn't. So I guess, like, I did have a question. Like, what is the name of the scale that goes from like A through F versus the ABC, because the ABC scale is really easy to find.
Yep, that's the Gardner
I
scale.
can't
That's so
find any data from like the broader scale. So I
yeah.
don't know.
So the guy who made it's called Marius. And so Marius used to work out in Dallas. He was one other thing, and he probably created half the embryologists out there. And so that's the scale. So a lot of people call it the Marius scale. Other people probably changed the name, but that's where it came from, was Dr. Marius. And then the other scale is called the Gardner system. That's what most people use. It goes by different ways. Some people call it ABC. Some people call it good, fair, poor. There's one place even I think there's a clinic in town that even does like gold, silver, bronze, or something like that. So, but it's all the same principle. But I try to explain to people, like, if you think about it, and I make the joke all the time, if you have to grade all people by 1, 2, 3, I always make the joke that Brad Pitt is 1, I'm a 3. I don't even have a choice of even being the 2 ever. But if you make it 1, 2, 3 through 6, right, and Brad Pitt's a 1, I can maybe be like a 5, maybe even a 4, because now it's not ridiculous. It's like, okay, Brad Pitt's 1, Dr. almost can't be a 2 in looks, so he's got to be a 3. And that's my point about embryos. When you're able to spread them out more, you can really tease out the best ones. Because if you think about it, if it's ABC, the worst embryo on earth has to be a C. So which means if anyone's grading an embryo and saying it's a C and they're transferring it, you're saying the worst embryo ever on earth is in the same category. That's the problem with that grading system. It shoves everything between basically A and B, whereas ours is able to separate them a little bit more. So,
Are more clinics moving toward I guess we'll call it the Marius scale?
I don't think anyone's moving to it. I think it's just what you've been trained with and kind of what you start with. I know, like, for example, in our town, Dr. John Kavaris, he uses the same system as us. I think most other people use the Gardner system, but there's many people out in Denver. I know there's clinics that use it. So a lot of clinics use it. It's just kind of what people do. And in the end, it's not wrong or right. It's just, again, it's our ability to figure out which are the best embryos and to be able to use them. What's hard for patients is you're right. They get a BB embryo and they're like, oh my God, this says it's only average. And like, oh no, that's like very good here. Like the A's are rare. A's are just, again, like A's are like Jesus, right? And then like the F's are the worst. So that's what scares patients, is because they don't realize that, they're looking at the system they see online, which is mainly the Gardner system. So.
Gotcha. Okay, well, if I have time for one more question, I'll go for it.
Yeah, go for it. And then we're going to go somewhere else after that.
Awesome. So this is more about, I guess, we went into our first retrieval, both of us, like, with my wife and I have very different bodies, right? Like, I have PCOS, she has low AMH. Like, I had a ton of follicles, a bunch retrieved, and she had far fewer follicles. So it was really interesting for us to go through this process and learn together.
Yeah.
What I wonder though is, like, what advice would you give someone going into this process so that they can advocate for themselves when it comes to, like, when you're watching your follicles grow, you're going through ultrasound after ultrasound, you're seeing your follicles grow, and then maybe like now you're coming up to trigger time. What would you like tell patients? Like, is it just always trust the doctor? Like, when they say it's time to trigger, it's time to trigger? Or is there a point where, like, you give them some advice to say, maybe ask if you can wait a little bit longer or trigger sooner? What should they be looking for?
Yeah, that's Sam. What do you have to say about that? I could definitely give my input on that too, but I'd love to see what you have to do.
Yeah. So Cassidy, I mean, I just want to make sure I'm understanding it right. You're thinking about, okay, you're going through IVF and you've got, this group of follicles that are growing, and you're saying, should you kind of weigh in terms of like your opinion for when to trigger? Is that am I hearing that right?
Right. So exactly. Like, if you're afraid that, my doctor's telling me to trigger, but my follicles seem too small, or my doctor's telling me not to trigger, but my follicles all seem huge, what advice would you give someone in one of those situations?
Yeah. I'll start with a little example of how this this is like something really similar. There's other similar examples in medicine. So, for example, let's say you're having a surgery done, and that surgery, the goal of the surgery is to, remove one of the ovaries, because maybe there's like a tumor on that ovary. And as you're going to, remove the ovary, Dr. Amos and I probably have 15 different ways that we could approach removing an ovary. There are slight variations of that. But at the end of the day, I probably became comfortable with 2 or 3 that work best to get that ovary out safely and to accomplish the goal of getting the ovary out. And, 1 or 2 of them might overlap with Dr. Amos, but he might know some secret techniques that I don't know. And he kind of uses them sometimes because they work well for him. The idea here would be, if a patient were to be like, hey, I want you to use Dr. Amos's technique, I, as the surgeon, might not do as good a job because I would say, I'm not familiar with that. Like, I'm trying something that now I don't know how to do. But B, I know how comprehensively I can do the surgery and do everything and get everything to work really well for you. So when people kind of chime in on these very nuanced medical decisions, I think a lot of times what they're doing is they are deviating the doctor away from something that they are already really good at. You got to remember, how many IVF cycles have you been through? 1, 2? How many have we been through? Thousands, so we have a special expertise in this, and that's why people are coming to us, because hopefully people don't want to make all the medical decisions of these, very nuanced decision points. They want to make decisions about, I want to go through IVF, or I don't want to go through IVF, or I would like to have, 2 children in the future, or something of that kind. But that's kind of how I would sort of think about it. So, my short answer is, I don't think this is a place where you'll get a lot of benefit, and you actually might end up hurting yourself by kind of saying, I don't want to trigger today, I want to trigger tomorrow type of thing. But I don't know, Dr. Amos, like, how would you think about this?
Yeah, I think it really, it comes down to the question I think that you have, Cassidy, which is, you're nervous about something, right? This is a very anxious process to go through. You have everything on the line to lose. And in the end, the doctor doesn't, right? It's true. I have to make these decisions. And obviously, I'm stressed about it too. I want it to work. But as a doctor, right, I'm the one, if it fails, you're the one that deals with it. And at the end of the day, I don't. And so I think the main thing as an advocate for help is talk to them. I have people ask me all the time. They'll say, hey, can we go another day? And I say to them, well, listen, let me explain to you why there's a concern going another day versus not. There are times I'm in a situation sometimes where it really doesn't matter. It actually isn't that precise. And I think that's the question you're coming at is, hey, how precise are things? Like, does it have to be right this second? But Dr. Sam was correct. We see thousands of these, so we know the outcomes of these things. And so I say, talk to your doctor. When I tell them is I go, listen, we can wait another day. And it sounds great. But keep in mind, you have all these follicles here that are big. If I wait another day, all of these get bigger. And sure, you're going to get more mature eggs. But the problem is now you're going to get post-maturity and they may not be as good quality. You're going to feel good. You're like, oh, I have so many mature eggs, but you won't have the good quality. It's a fair question to ask. And obviously, you shouldn't, this is my personal thing. I don't think you should ever be with a doctor if they're not willing to talk to you. I think you should always be able to ask questions. You should never be told you can't ask a question. Looks like Dr. Salem fell off or said, we'll get him back on. There he is. But you should always just talk to your doctor and just ask them. And they should tell you why it's a good or not a bad idea. But I've had people ask me that, and I go, yeah, I think it's reasonable. I said, just understand this is why I would do it. Do you want to take that risk? Now, there are times people ask stuff. I say, you can't do that. You'll hurt your chances. It's a horrible idea to do. And I explain it to them. And then that's the point where, in the end, as Dr. Salem said, the reason you're going to certain doctors is for their expertise. And you want to make sure you have someone who you feel is being an advocate for you. If you feel they are, then you're in good hands. So, but just ask. Never unfair to ask that question.
Awesome. Well, thank you both. I appreciate your time.
Yeah, you have a great night. Thanks again for the conversation.
Yeah, you too.
Well, I know we got someone in the background here with a really cute kid in the background. I saw. So I wanted to talk to
I'm
Rebecca.
not a kid, but thanks.
No, the kid was there. I saw her. But I saw you had a question for us, Rebecca. I think you kind of wrote it in there, but I'd love to hear your question for us and Dr.
Yes. So my question is, we've done a couple cycles of IVF. One of them was with you. That's how we got the cute little 3-year-old. Thank you. That was 2 retrievals. We did another one at ARMS. I have low AMH, like really low, like maybe don't even try low. And we got 1 embryo and got really lucky and got our son, and
Wow.
really want a third. Didn't know that we were going to be in the boat that we thought we would want a third. I'm probably looking at coming back to you because honestly, you're just the most hopeful person. I know you're going to tell it to me how it is, but also you just have this hopefulness about you. 0.39 is my AMH. Like currently, I just did it a couple weeks ago, did the blood draw. And then the other clinic we've gone to is just like, just do donor eggs, just do donor eggs. And it's
Yeah.
like, I get it. I understand like that would be the ideal way to go. And I think if both the kids were donor eggs, it wouldn't be this weird conflict in my head. But it is. And so I guess my question is, with it being that low, is it really as hopeless in my head as I'm thinking? Is there any possibility of like, is it worth going through and spending, it's expensive, 100% worth it. But realistically, is this like a fantasy pipe dream with 0.39 AMH? Or is it worth trying?
Yeah, well, I know Dr. Sam and I will be very similar, so I might have him go first and tell you what he thinks, but I can almost guarantee we're going to be exactly the same on this one. So,
Yeah. I mean, yeah. So first of all, like I know 0.39, when you think about it, you read the stuff online and you're looking at stuff, it's like, oh my gosh, I'm so low. But I'm not that shaken by it. I see that a lot. I see, AMH is below 0.5. And the idea here, of course, is that, we might not get a ton of eggs and the efficiency of an IVF cycle might not be optimal. But it doesn't mean that it's not going to happen. We have a lot of people who go through with low AMHs that eventually get pregnant. Now, where it's kind of like, okay, let's have real talk about this, is around the fact that, hey, if we only can get 3, 4, 5 eggs, we might only have 1 embryo to test or to try to transfer. So it might not happen on that first IVF cycle. We might have to just be prepared for that. But, I think that donor egg is wonderful. And and if you need to go down that route, it's a great solution. But I feel like if you're in your heart of hearts, you're like, I want to add another genetic sibling and I want to know that I've tried everything to do it. I think our role as fertility doctors is not to tell you go to donor egg. Our role is to figure out how to optimize your chances with what you want to do. And so I think there are some things that I'm hearing that are very positive prognostically. Like, I don't know what your AMH was the first time you went through, but it probably wasn't super high and you were successful.
It was 0.57 in 2023, and it's gone down to 0.39. I mean, that seems fast. I don't know, but it's pretty fast. I don't know. I'm not a fertility doctor. I have no idea.
Yeah.
But
Again, that number, that trend, it's not like out of the norm, and a lot of this has to do with your age, and a lot of it has to do with like your FSH as well and your antral follicle count. So there are other parameters that are very, very important that we have to take into consideration as we do all this. And then it's about getting to work and doing the hard work to try to optimize everything that you want to do. I don't know. What are your thoughts, Dr. Amos? I mean, I think, obviously, Rebecca a little bit more.
I know her a little bit better. That's why I didn't take it first, because I thought I'll put you on the spot of not knowing her background. So first of all, she's young. So she's very young. I mean, I know you probably don't feel that way, Rebecca, but I would consider that you should be about 31 now. So
yeah,
I would consider
that was spot on.
you're pretty young. That is probably one of the most important factors. I'll be honest with you, I'm never scared by an AMH. It never scares me because it is probably, I think, one of the most least prognostic factors when it comes to the fact of being able to get eggs and things like it. Let me take a step back, explain things. So ovarian reserve is just a measure of how many eggs you can get. So as Dr. Salem said, it's going to be harder. There's no question. That's what your AMH says. It does not mean you can't get pregnant. I'm telling you, I've got people pregnant with non-existent AMHs when it's less than 0.03. And not just once, multiple times. So it never worries me. What worries me is when I look at the whole picture. So if someone has your AMH and they're 41 and their antral follicle count is 2 and their FSH is 16, then I too am going to tell them that, listen, I'm more than willing to try with your own eggs. But realistically, you're going to throw a lot of money away doing this. That's where donor eggs comes into play. I hate when I hear that doctors tell women young like yourself who have kids, oh, you should go to donor eggs. They're right from a mathematical standpoint. Yes, one cycle, you're probably going to come away pregnant. In your situation, it's really more about where the other parameters. So again, the AMH means nothing to me. I actually have a patient right now, very strange. Her AMH was like 2.5, and then recently tested it, it was like 0.7. And she has a ton of follicles on her ovary. Ton. She almost looks like a polycystic person. There's something about AMH with when they run it and the way they run it, there's different ones that run it. It just sometimes comes back weird like that. I've had patients with polycystic ovaries come back with almost 0. There's just, it's weird. So that's why I don't ever take that number as its value 100%. I use it as a tool looking at everything else. And so as Dr. Salem said, what really matters is what is your antral follicle count, okay, and what your FSH level is. If the antral follicle count is decent, then that means that's your potential every month, right? Every month you can maybe get that many eggs.
Okay.
The FSH, even when it's elevated, I've now with a new protocol, and I know Dr. Salem uses something similar to me with using letrozole and using stimulants at the same time. I've got patients pregnant with FSHs in the 20s and even as high as 25. So we can do a lot more now. And what we've learned is age beats everything. Now, there is a point where if you don't have a period anymore, obviously we can't do it, but that's not the situation here.
Right.
And so I think that's where, not that, I'm not going to say that we're better, but I think you just need to have a doctor who's going to look at all that and has some of those extra tools to try things that are a little more customized. That's the one thing where you find people fail is when you just do the same thing over and over in patients with severe diminished ovarian reserve is you have to adjust a little. You have to adjust to the person and their labs and what the situation is. But yeah, definitely don't go to donor eggs. That would be crazy.
And then progesterone pill versus shot.
So the doctor that you work with, I know I thought has changed that. You're talking about for support in the pregnancy, right?
Yeah.
No PIO with a frozen transfer?
We did. Yeah, you're right.
Yeah. It's not recommended. Obviously, people can get pregnant with that. It's not 0, but there is a decreased pregnancy rate in studies that show that if you don't use PIO or a certain vaginal at a certain point, that you do have slightly lower pregnancy rates. So that's why pretty much most clinics will use at least injections, and then eventually we'll combine injections and suppositories and stuff like that. So.
And then as far, I lost it. What was I going to ask, babe? I lost it. It was right there. It'll come to me. I'll type it in the chat.
No problem.
I would be more than happy to answer. But
yeah,
please. I know that obviously you're not with us not because you don't want to be, but for other financial reasons stuff. And what I tell you is that feel free even just to talk to me. We can sit down, but do not jump to donor eggs at this point. Make sure you get that second opinion because I can assure you, you are not the patient who should be jumping straight to that. So.
Yeah. Well, thank you. I appreciate it. Thank you guys.
So great seeing you. See the little one and your bigger one I saw.
Yeah, the bigger one was the one. She's the one you got helped me. 2 retrievals, 6 transfers, removed the fallopian tubes.
Yeah.
That's why when I saw the other people, I was like, "Don't give up. It can happen. The struggle's so real, but it's so worth it."
Definitely a journey. Well, thanks so much.
Thank you.
Yeah, we did a show on this one time. Remember we talked about donor eggs, and it really drives me nuts when I see places just so easily throw it out to such a young, couple and
Yeah.
say, oh, you should do donor eggs. And it's like, I know their intent is good.
Yeah.
It's just, I don't know. Is it just they don't have success there with those situations, what it is, but I never understand with someone so young like that.
Yeah.
One of my favorite cases, the one we have at our clinic, it's actually our nurse. I'm not going to say her name for her first, but one of our nurses, I mean, literally non-existent AMH, FSH through the roof. She was about 21 years of age, and she's going out with a couple pregnancies here, and so it just shows you that those numbers do not define you and whether you're going to get pregnant or not. They just say, are you going to have an easy journey, or is your journey going to be a little bit harder? So
yeah, no, just on like that same exact point. Like, since we're doing the myth busting thing tonight, one of the biggest myths I feel like is AMH and how predictive it is of like quote unquote natural fertility. And so there's a company out there, there's a few actually, that try to make it a point to say, hey, if you get your AMH, you're going to know what your natural fertility is. And there was a great study that was done by a group at UNC, and it was published in JAMA, which is kind of like the Sports Illustrated of medicine. If you're in there, you're doing well. So it's a really big study, really important study, and what it showed is that the AMH was not predictive of your pregnancy rate over the next year. And so what it told us is that people that had a low AMH and those that had a high AMH from, right out of the gates, if they were trying to get pregnant, both groups got pregnant at the same rate. So it was not predictive of your natural fertility. So again, hopefully that busts one of the myths that's out there. That one's pretty well proven. It's more proven than some of the ones I'm seeing here around moonstones. So we can get to some more of those. I know there's some other people here that have some questions, so let's go to those.
Yeah, so one of the questions I saw here was, I thought it was a great question, was after a chemical, so I'm assuming pregnancy, do you suggest any other tests to see what the issue was? That's kind of a tough question because when it's a chemical, you really don't know exactly, what happened. But I do feel, I don't know if you do this, I will draw the blood very early. So for example, I'll draw like on the 5th day, the 7th day, the 9th day, before day 10. And what I've found is over time now, and again, as you mentioned, we do thousands of them. I mean, I've seen so many of them. I've been able to notice there's a trend between different types of miscarriages, whether it's implanting right, whether it's a slow implantation, is it going up and then dropping fast? And using that, I feel like I'm able to kind of get a good idea of what's going on. But other than that, there's really not a lot of tests unless, this is repetitive over and over and over. And then you start thinking, okay, is there something else going on? But I was just wondering, what do you think about that? That when you have a chemical pregnancy, and obviously that's a very broad category, right? That's anywhere from, it starts with a 4 to all the way up to maybe 800, and you never saw it in the uterus. Yeah. But what is your thought on the low level chemical pregnancies? And then I guess the second one would be the high level, chemical pregnancies.
Yeah. I mean, I think it's like one of those great mysteries in our field still, right? Like, we'll throw out the question kind of like this, like, we can have a perfect embryo and we still seem to hit a ceiling of about 70%, implantation all the way through to, live birth rate. That's with the best quality embryos. So what's that 30% that we can't seem to crack? And it's probably some types of implantation issues. And I think a lot of biochemical pregnancies fall into that group. Now, we don't know for sure yet. Like, the research is still ongoing. This is one of the big, mysteries in our field that we're still trying to solve. But with biochemical pregnancies, I think if you have one biochemical pregnancy and you have a batch of really good embryos and you've never had a miscarriage before, the number of tests that I could do for a patient are from the floor to the ceiling, but they're probably not going to help that much. Probably the most helpful thing for the vast majority of women is just to move on to the next embryo transfer. And for most women, that second embryo transfer leads to a pregnancy and a baby, and they never even think twice again about that biochemical. Now, obviously, if you have like repetitive biochemicals, repetitive miscarriages, sometimes there's more than meets the eye there. And everybody always asks me, they're like, well, why are you going to wait until that happens? And the reason is 9 out of 10 people, it's not going to happen to them. And so why subject them to all this invasive testing and everything? And it's very unfortunate for that 10th person, but usually that's when we start kind of looking and doing a deeper dive.
Yeah, when I look at that very low level, I do feel like I can tell the difference between if it's implanting or some of the things going. There's actually a certain pattern I've noticed where I realize it could be an issue, where it could be a timing issue. I actually did a podcast on this about whether to test or not. And it was one of the pros. I said that one of the only good things about testing early is that if your day 10 comes back at, like, let's say 0, but you tell the doctor, well, actually I had a positive, or, around day 5 and 7, at least we know what the implant is. We know the issue then is either something wrong with the implantation or the embryo was already on the way out, depending on how that was. And I agree with you. I think we do put back embryos that are dying all the time. And we don't know it because, as I always say, you and I, we can tell if we're sick. But an embryo, it's chemical signals that we're not going to be able to know about. And it is very possible we thaw an embryo and we're like, that's a beautiful embryo. And that embryo is already dying and we don't even know it. And that could be part of what's going on here. So I was going to hit another question here. This is one that 2 people asked, so I thought was a really good one. It was actually one of Rebecca's questions. So I thought a great one to put on here. And that is, do you recommend PG testing for everyone going through IVF? Now, her question was slightly a little different. She was saying, hey, we only had like 2 embryos. Doesn't make sense. And so I'd love for you to answer that. I'm going to start with Rebecca's question. With hers is, what if you only have 1 or 2 embryos?
Okay.
And in her situation, I would say that I still think it's useful. I always tell people, I think one of the benefits of PGT, there's actually some papers on this. Dr. Richard Scott did one just recently about like time to pregnancy and like not wasting time. And I think anytime you have severe diminished ovarian reserve and you have a window of time that is closing, it's always beneficial because of the fact that you're able to say, hey, I have a normal embryo now, I can stop, or I have to keep going, versus if you do a transfer and the embryo is abnormal, now you have a miscarriage, now you're, another 4 months until you do this again, and now your ovarian reserve is even tanked more. So I think there is always a benefit in that situation. Now, do I think that if someone's 22 years old or they're using a donor that they have to do it? No, they don't have to, but I don't think it hurts anyone's chances. And I basically tell everyone, if it was free, I tell everyone to do it. I don't believe it hurts the embryos as long as you have a competent, embryologist and things like that. So love to hear your view on this as well.
Yeah, no, absolutely. So I think, we'll just tackle the question just at face value, right? Do you recommend PGT testing for everyone going through IVF? Well, it's pretty easy to answer this one because, there's very few things in medicine where it's absolute, like everyone, or do you have to, or whatever. So I don't think that PGT testing is recommended for everyone. And there are probably some groups where, I might talk through it with patients and tell them, you know what, I honestly don't recommend it. One group would be, very young patients who are trying to be as cost efficient as possible. In that group, we might want to say, hey, maybe we don't have to do this. It depends how you're using it, right? So I think it's always worth a conversation with your doctor about, what is PGT going to do for me? It's a screening tool. It's trying to identify the best embryo for a transfer. It's trying to make you go through the least amount of trouble, pain to get to your baby. And it's not doing anything to improve the embryo. It's just helping you figure out which embryo to use, or to just move on from that IVF cycle to the next IVF cycle. So I think it's a little more nuanced than just everyone should always forever use PGT testing. You should also know what your clinic's rates of, pregnancies are with PGT testing. I mean, I've seen that at some clinics, their rates are, lower with PGT testing than at other clinics. And it just begs the question of how expert are those embryologists at doing the PGT biopsy? Because if they're a little too aggressive, they can impact the chances of success of that embryo. Now, this is where it comes to all this nuance, the embryologist being very, very good, all these kinds of things. And so you just have to kind of know the numbers, of your clinic, of your doctor, et cetera.
Yeah, no, I agree 100%. Like I said, at my clinic, I feel comfortable with it. I know there might be other clinics where I wouldn't feel comfortable with it. There are a couple of really good questions here I think that we should hit up on. I like I said, I really like some of these ones. One of the other ones here, actually, I'm going to put back up here. What are odds of an embryo splitting, and do HCG numbers indicate twin pregnancies? And odds of an embryo splitting, it depends. If you're talking about putting back just one, then in that situation, about 1 in 240. With IVF, it goes a little higher than that, than natural, just because there's some questions about with ICSI and culture environment might increase that a little bit more. And then what is your thoughts, Dr. Salem, on numbers indicating twin pregnancy?
Yeah, I mean, so yeah, the odds of an embryo splitting with the stuff that we do in the lab do go up a little bit. So we do see, compared to the natural population, like a little bit of a higher identical twinning rate. It can be as high as like 1.5% in some studies. It just depends on the group that you're looking for. And again, this part varies a little bit. Now, how about the HCG number? So this is a funny one. I mean, broadly speaking, there are some patterns that we see, higher HCG numbers, etc. But there's a huge amount of overlap, right? So you could have a singleton pregnancy, just one embryo, and it's just pumping out tons of HCG. And then you could have a twin pregnancy that's perfectly normal, that's creating just about as much HCG at that same point in pregnancy. But generally speaking, you kind of see a trend towards higher HCG levels with twin pregnancies. But I think I was looking at a study. This is a long time ago. They were trying to come up with like a nomogram for this. And if I remember right, they were just saying there's too much overlap between the singleton and the twins.
Yeah. I've seen some numbers, the highest numbers I've ever seen in a patient, one baby there.
Yeah.
And I've seen other numbers where super low and there's twins. You really can't go by that. When I was at Mayo, we did a study where we were looking at HCG numbers, and we were basically trying to figure out where would the HCG be when certain portions would occur in development of the embryo. So we also know about the discriminatory zone, which is when we expect to see something in the uterus, which for some places can be 1,000, could be up to 2,000. But we want to figure out, like, when will the yolk sac be there? When will the embryo be there? When will there be a heartbeat? And the numbers were so wide the range that it was basically useless. And so what we found is you can't even use that to determine, like, hey, we should see a heartbeat now or something like that. So, but like I said, a really good question there. And I think one fun fact that many people don't know is when we talk about twins and we're talking about identical, and then people go, oh, my husband's identical twin, that there is no identical twins running in families. That is purely just a chance situation. When we talk about twinning, we're talking about fraternal twins, and we're talking about on the female side. I feel bad because I know Steve's in the background. I want to talk to him too, but here's one that's really good. I like this question. This is a really good question. And I really am interested in this one, which is, why is it when a patient comes in, they don't give them different options for IVF up until the process fails, and now you lost all this money? And I know exactly what she's saying. She's saying, hey, like, why when you come in, like, we don't put everyone on growth hormone. We don't do ICSI on everyone. We don't do assisted hatching on everything. Why do we start with this protocol and then we go, oh, we figured this out? And it's very easy to look at this and go, like, why aren't they putting the best first? And to me, I think really what it is that they are putting the best first. So they're taking your information and they're picking the most cost-effective, best protocol possible. And what happens is that when you go through IVF, then they learn things. This is the one thing that IVF does over any other treatment, is you can learn and figure out where there are problems. Patient I saw today actually was a follow-up. They're coming back through, went through IVF, sperm looked fine. We did standard insemination. That's what I would recommend, and had no fertilization. Luckily, with rescue ICSI, they were able to get one embryo, and that embryo led to their son. And it was a cute little guy too, by the way. But now they're going to do it again. And now I know we have to do ICSI. Even though the sperm looked good, I'm doing that. And it's not that I held back on it. It's just the fact that we didn't know that. And so I would say that if doctors gave people choices, they wouldn't be doing what they think is best. But back to our point we talked about Cassidy, which is talk to your doctor. If there's something you want to do, sometimes they're not doing it to save you money. For example, I don't put everyone on growth hormone. It's not beneficial for everyone. And some people can say, but it might help. If someone says to me, I don't care about the $1,000 I have to spend, I'll say, okay, let's go on it. There's no harm to you. We can do that. Same thing with things like embryo glue and stuff like that. There are certain things that empirically don't always benefit you. And so we're trying to do our best to also not cost you too much money, but on the same token, give you the best protocol. But no one ever picks a protocol just randomly. It's always based off of what they have. And unfortunately, I wish our bodies really had like an announcement of, hey, I'm going to have this problem, but it doesn't. Instead, we find out as we're going through. And it does feel like trial and error because the human body, unfortunately, doesn't always follow the rules. What's your thoughts, Dr. Salem?
Yeah, no, I mean, I see the conundrum here, and I think this is like almost like like the classical like Monday morning quarterbacking, right? And you're just kind of like, well, they should have done this play, they should have done this, or but then for all the people for whom it has worked very well to not add up all these add-ons, they would say, you wasted my time and money adding all these things that I didn't need. So it's very difficult to know with certainty. Now, obviously, we have like all our diagnostics, all these things that we do, but I'll just leave it by saying, I think that you do learn from IVF cycles. You do add things in as they become apparent that they're necessary. And for most people, that process tends to work much, much better than just throwing the full kitchen sink at it from the very beginning. But I think it goes back to this point of yours, Dr. Ames, like talk to your doctor, because maybe cost is not at all something that you're concerned with. And you're like, well, yeah, add this. It's okay by me. And that's an honest conversation that you should have with your doctor.
Yeah, I've had patients come to me from other clinics and say, like, they put me on all this and it cost me $25,000. And I'm thinking to myself, wow, like, they didn't need all that. And then we do something much cheaper and they get pregnant. And they're like, oh, now again, I have the hindsight now of knowing what didn't work at the other place. But that's a way some people practice medicine. There are many clinics. It doesn't matter who you are. Every single thing is just thrown at you.
Yep.
And it's kind of thought like, hey, I'm not going to customize. I'm just going to, if I give it to everyone, I won't miss out on anyone. But it costs many people more money than they need to spend. And it also puts people doing treatment that they may not need or could potentially have some effect. So it is frustrating. I wish there was a way that we could guarantee it there, and say like, hey, if there's a problem, what I can tell you, at least at our clinic, and I know I do this, is if I'm telling someone they don't need ICSI and they don't get it, we feel horrible because we help make that decision with you. Even though we're giving you the choice to decide if we can do ICSI or not, we're still trying to make that choice for you. And we help our patients out in those situations, which are very rare, like maybe 1 or 2 a year that anyone has zero fertilization. And that's when you want to make sure you're at a clinic or something that looks at the patient not just as a number, but looks at them as a person. And if those things do happen, at least you have a clinic that will help be behind you. So, but great question. One of the questions came up is, by the way, at least someone's listened to my podcast, it sounds like, is they listened to Taco Tuesday last night. And so just so you know what I spoke about last night, Dr. Salem, I was talking about the week before I was talking about the statistics of fertility. And then I wanted to talk about this change where, again, many of us, any place taking insurance is going to have to be forced now to follow 100% the ASRM guidelines, or you're just going to lose contracts. And I wanted to talk a little bit more about the math and kind of explain that even though, thinking putting back 2 gets you a higher chance, it's only short term. And that technically putting 1 back at a time ends up leading to a higher chance to even put back the 2. And so this person was asking, they just turned 41 and wanted to know, would they recommend 1 or 2? And as you say, we did 2 last time. 1 was a day 4 embryo and 1 was a day 6. We only got 2 last time. What's your thoughts?
Yeah, I mean, so, would you recommend transferring only 1? When the idea here also, I'm just reading between the lines here. I'm assuming these are PGT tested embryos. I mean, that's, again, the ASRM criteria that we're talking a lot about is these PGT tested embryos for women 35 and older. So, with one single PGT euploid embryo, you have such high pregnancy rates that it's better to do one at a time. Because again, putting two in at a time really only bumps up the twinning rate, which is associated with all kinds of, added risk, let's call it. And it also, your cumulative pregnancy rate of those two embryos is lower. But yeah, what are you thinking on this one?
So I actually, because it says day 4, I'm assuming it means stage 4. So these are probably not tested. And I think the important question here is, when were the embryos made? So it's not about your age currently. It's always about the age when the embryos were made. And I think the most important thing, as I try to talk about in this podcast, the goal is aligned with yours, which is to get pregnant and to have a healthy pregnancy. And so as I talked about in this podcast, where I said, whenever you put back 2 embryos, you now have twice the risk, because each embryo itself has a risk of things going wrong, subchoric hemorrhages, ectopics, and then that could lead to you losing both embryos. So as Dr. Salem mentioned, it's an age-based system. And so if you are younger and you're talking about non-tested embryos, it's almost always going to be 1. As you get more mature, it's not unreasonable to put back more than 1, because now age becomes a factor, because the percentage of embryos that will be euploid are lower. But per ASRM guidelines, if it's your first transfer, really anytime you have a euploid embryo, unless it's extremely poor quality embryo, you really should only just be doing 1 at a time. And so obviously this question we can't answer directly because we don't know if they're going to be testing or not. But in general, that, those would be the guidelines. And I kind of laid them out last night, for each group category, so people would understand it. I know we're getting near the end of time here. I was looking at some of the questions here that I thought are pretty good. One of them was on Instagram. It's a great question. I'd love for your opinion on this. Does age matter for implantation if the embryo is donor conceived? So basically, I'm assuming a young donor, under 35, does it affect it? What's your thoughts, Dr. Salem? I think you're on mute.
Oh, sorry about that. Say that again. I think I just missed one part of it there. It just cut out on my end.
And by the way, we do have one guest. I apologize, I didn't see them on there, so we will get to that guest before we get off. But it said, the question was, does age matter for implantation if the embryo is donor conceived?
Got it. Sorry, I missed that one critical part. So a lot less so, meaning that when you compare, women who are 30 to 45, just more life has happened, right? And so what does that mean? Well, there's an increase in the chance of having a fibroid. There's an increase in the chance of, having some sort of chronic medical condition in the background. Or maybe, like most people, we all gain a little bit of weight as we get older. And so, there's all these little things. So there are some little things that make it so that the implantation rates might not be quite as high, but boy, they're really close. Because when you're using a donor-derived egg, a donor-derived embryo from a young donor, that's the lion's share of importance, is that you have that, high quality embryo that's going to implant. Another way to say this is the uterus just doesn't age the same way the ovaries do. And so when you take a good quality egg and put it, in a uterus, whether that uterus is, 35 or 38, there's very little difference, between those numbers. A lot of it just has to do with, your baseline health and those things.
No, not much I can add to that either. I agree 100%. And I think the point that someone should feel comfortable about is this. People who are surrogates are sometimes even menopausal. People use their moms to be a gestational surrogate for them, and things go fine. Yes, there's slightly higher risk because of the age, and there's but again, these are very small. So I agree 100%. So again, I feel bad. I did miss that we had another guest here, and so we'll definitely bring them on. I feel bad that I did not see them. Hey, Shayla, how are you doing? Hey, Aaron.
I'm great. How are you? Hi.
Good. I know them. That's why I knew their name.
So I have two quick questions. The first one, the first one is, it's so easy to get discouraged with the process of IVF but in the process of it, it just over and over again reminded me how much of a miracle it is that we have this available to us, and that people can actually do this on their own. Like, that's just, it's crazy to me that how hard it is for us to get pregnant. Someone can get pregnant naturally, even with twins, naturally. It's crazy. So I was just wondering, with your guys, with your work that you've done, how, if there's been stories that you've come across where it's like, oh my gosh, this is just, it blows your mind that you know, it can result in a pregnancy, or just like the odds are against them, and just a story to maybe give some hope that that this is still a good route to do. But then also the second question was for a guy during the giving the sperm sample in preparation for the
was actually my question.
Yeah.
So the room where we give the sperm sample, honestly, it's just kind of uncomfortable.
It's in all clinics that we've been.
And yeah, in every clinic we've gone to, I find myself just kind of like laying on the floor and putting my hips up in the air to try to get the sample into the cup. And so I just wondering
every drop.
Just wondering if it doesn't particularly make me feel relaxed or anything like that. So I was just wondering if you.
But just the pressure of wanting to give a good sample. Like,
any tips for how I'm supposed to use that chair in there?
Yeah. I can tell you as myself and my wife who've been through fertility, I'm so thankful that we have what we have around. I mean, I tell people all the time, 10 years difference that I was born. If I was born 10 years before that, and I would not have kids. I mean, from me, at least they would have been donor sperm 100%. So I agree with you 100%. It is just amazing, the technology we have, and it's only getting better with time. When it comes to hope, what I can tell you is, if you can make eggs, it can happen. I've seen some of the craziest stories. I'm telling you, they're one of my favorite stories I love to tell. It was about this patient. She was around 25, very severe diminished ovarian reserve. AMH less than 0.01. FSH, I believe, was around 20 something, like maybe 22, 23. She was actually at CCRM. She was actually going all the way to Colorado, the mothership of CCRM. And within like 5 days of stimming, they just canceled her. And she's like, I've started all this meds, and we were doing her monitoring for her, and they just canceled her. And we said, no, we'll keep going. I said, there's a couple follicles there. We didn't care about if someone only had 2 eggs or 1 egg. And she got 2 kids out of that, from those 2 follicles. And so you can see where someone else might have gave up, right? And another clinic said, no, let's go. That was the one that worked. And again in the future. And there was one of my patients, one of my favorite stories I like to tell patients is that I had this one patient. We were going through, and every time we were getting like 3 eggs. That's all they could get. And there was this one time she was only making 1 follicle. And, cost-wise, they're like, I don't know if I want to do this. It's 1 follicle. And I don't know why, but I'm a very kind of spiritual person. There's something in me that's like, this is a test from God. Like, we got to go forward with this 1 follicle. And so I didn't want it to be a financial decision. So I said to them, listen, do me a favor, go through with this. If it works and you get an embryo from it and it comes back normal, then we'll keep the money. But if we don't, I'm not going to charge you. Something tells me this is like, because we kept getting negative, abnormal embryos every time. And that was the one she got a normal embryo on. And she had a child from that. And, it was just one of the weird things, like, it's just like I said, spiritual. And I love to hear Dr. Salem's, because I'm sure he has some great stories too. But for Aaron, I have given so many dang semen analysis in my life. And I've done it. And you think your situation was bad? Imagine being at a clinic, seeing patients They tell you only have, let's say, 5-10 minutes, and they're knocking on the door going, Dr. Amos, you have patients. I'm like, what are you doing? I'm trying to give a sample, and everyone knows what you're doing in there. It could be much worse. I don't think it's ever good, you know? And it's funny because people will be like, oh man, why guys don't want to do it? No, we're not against doing the act. The problem is that everyone knows what we're doing. We're in this weird room, and we're not, you know, you're making too much noise. Did you go too fast? You know, did you go, you know, and so what I can tell you is I've never seen like a champagne room yet for semen collection. But you are right. They are never that great. What I would tell you is if you are close, some clinics do let you do it from home. And so, you know, obviously when some people have some sperm quality issues, it's not always as ideal. But, you know, I mean, you can bring some stuff with you. Bring like a table or something, you know, and bring it in the room with you. So my trick, though, is I will give a trick, which sounds funny, but this is a guy giving a guy. I felt that leaning a little bit at the angle with like hand up there, and you know, and that was the easy thing, like a lean. That's what I felt. But there is a guy who actually made an ergonomic collection cup, and I wish I had it with me. If I knew you were coming on, I would have brought it. I did like a funny TikTok on it, but this cup actually has like a 90-degree angle, so you can shoot straight into it.
Oh, cool.
So if you ever really do want that, I think the guy sells them. I think they're like $70, $100. But there is an ergonomic cup for some of us that, you know, like I said, so we're not on our backs lifting our hips up. So
Gotcha. Thanks.
Thank you.
And one more thing, the most important part is the first part. So worrying about all the extra parts, the first part is really the most important. Everything else after that, not as concerning. First part's the most important. Dr. Stan, what do you have to add to all this?
I mean, I don't know how much more I can add to that. Like, you know, insider tips on the collection room there. I think I think basically the biggest part here is that I think a lot of guys put a lot of pressure on themselves. Like, I got to get the best sample ever. Like, this is game day. I'm going to get the best sample ever. And the reality is that what you're seeing there, it has almost no correlation to the amount of sperm that's there. That is like a lot of like seminal fluid, you know, prostatic fluid, all these other things has to do with some of your hydration status. So I can't, you know, I've so many times, you know, after the IVF cycle, we go out and I'm telling, you know, the patient, hey, you did great. We got, you know, this number of eggs. And the guy's like, yeah, but how about my sample? I'm like, yeah, it's fine. Don't worry about it. It's great. It's going to be plenty of sperm for IVF. And I think the take home message there is for a lot of people, you know, it doesn't have to be like the best specimen or anything. It just needs to be a solid specimen. And, you know, to maybe hopefully that puts like a little less pressure on things. And that room is never going to be great. It's never going to be comfortable. I don't know how else to say it.
So the quality isn't too affected by like that day, anything that day, or the mood or anything like that for the guy.
That's right. Like the volume of sperm is the thing that a lot of guys pay attention to. And that is a lot less important than the parameters of the sperm.
And it doesn't matter, as you're saying, it doesn't matter if it's happy moment or a mad moment. It's still good sperm.
Yeah.
Okay.
Thank you.
Yeah. Absolutely,
Thank you,
guys.
guys.
Well, thanks so much.
Yeah. Thanks for coming on.
Well, I know we were a little bit longer than we were going to be, but I felt so bad that I missed them below. So anything you have to end on, Dr. Salem? I mean, it was a fun show. I didn't know I was ever going to share my my collection techniques, but, you know, I feel like I've made a difference now in the world. So
I think we've put it all out there tonight. I think this is great. We'd love to do more of these. Ask us anything. You know, we've gone to collection techniques. I don't know how much further we can go. So just kind of bring it on, and we're happy to go through all this stuff with everyone here.
Absolutely. Well, thanks for everyone who came on. And again, next week is going to be an amazing episode. You please come on and talk to this doctor. This guy is really phenomenal. He's a great surgeon. And he goes by, I think it's the Fibroid Slayer, right?
Fibroid Slayer. That's right.
Yeah.
Look him up. It's
Johnson. He's out in Chicago. So you're going to love it. We'll be posting about it here tomorrow, and you guys can start already getting your questions in. Have a good night.
Take care, everybody.